Good morning, welcome, and thank you for joining us today for the meeting of the New York City Health and Hospitals Finance Committee. Today's meeting is officially called to order. First, we want to adopt the minutes of the Finance Committee meeting held on October 18th, 2021. I just have one amendment that I would like to include on the approval of the minutes, and that is the minutes do not note that we approved the minutes from the prior meeting. So the amendment would say, upon motion passed and duly seconded, the minutes of the Finance Committee meeting held on July 21, 2021 were adopted. So with that, I would like to propose a motion to adopt the minutes with the amendment proposed of the Finance Committee meeting held on October 18th, 2021. And I will go ahead and poll each member individually for his or her vote. Jose Pagan?
Yes.
Dr. Kath?
Yes.
Ali Hernandez-Pinheiro?
Yes.
Penioski Peña-Mora?
Yes.
And Alicia, is Barbara on?
No, she's not on as of yet. I'll let you know as soon as she gets on.
Okay, but we have quorum. I vote yes also, so the minutes are adopted. So we have a number of action items today to consider. The first, Dr. Amanda Johnson is with us, and she will go over the first action item. Dr. Johnson.
Hi, good morning. Thank you, Frida. Good morning, everyone. Just up front, really grateful for your time and the opportunity today to talk to you about our request for H&H to assume the Mayor's Office of Housing Recovery Operations COVID-19 Resource Navigation Agreement for the purposes of continuing resource navigation after care navigation as part of the Test and Trace Core. As mentioned before, I'm Amanda Johnson. I am a primary care internist who sees patients at our FQHC site in Harlem. I work with Dr. Long in the Office of Ambulatory Care and Population Health. But I come to you today in my role as the director of the Take Care pillar of the Test and Trace Core, which is the pillar that's responsible for providing supported isolation and quarantine to cases and contacts, New York cases and contacts during the COVID-19 pandemic response. I will walk through these slides, but please let me know if there are any items, concepts in here in particular where you'd like me to focus on or start with. If there are no requests or questions,
Dr. Johnson. Oh, yeah, Khaleesi, I was just going to ask, do we need to ask Dr. Johnson to read the resolution?
That is exactly what I was going to do. Thank you. We need to read the resolution into the record. Thank you.
All right. So I'm turning now to the resolution in the packet, and I will read it. Resolution authorizing New York City Health and Hospitals Corporation, the system, to assume requirements contracts with each of Bronxworks, the Chinese American Planning Council Incorporated, and the City University of New York Graduate School of Public Health and Health Policy, the agencies from the Housing Recovery Operations Unit of the New York City Mayor's Office, HRO, to provide client engagement services in connection with the Test and Trace Resource Navigator Program, RNAV, and the Aftercare Program, ANAV, for the period January 1st, 2022 through June 30th, 2022, for an amount for all three agencies not to exceed $17,273,816. Shall I continue? Okay. Whereas HRO was tasked by the city with procuring, contracting with, and managing organizations to perform client outreach with COVID-positive New York City residents referred by the Systems Test and Trace Core, T2, and COVID Hotline is needing supportive services to assist them during a period of quarantine or isolation as part of the RNF program. And whereas HRO performed a procurement of the agencies that complied with the standards of the Mayor's Office of Contract Services for COVID emergency procurement, and whereas based on reduced needs and confirmation of the good performance of the three selected agencies, HRO determined to retain only the three agencies whose contract it proposes to assign to the system, and whereas the RNAV and ANAV programs fit together with the suite of programs administered by the system with T2 producing names of COVID-positive persons, identifying those required to quarantine, isolate, identifying those in quarantine or those with long COVID requiring supportive services to maintain quarantine or to support their recovery, and various other programs such as the Get Food program providing the actual services required, leaving to the agencies to work directly with the persons who need assistance to determine exactly what services are required.
Hey, Amanda?
Yeah?
You could jump right to the slides, actually. I know that the committee is on a timetable here.
Okay. So I will stop reading the resolution and I will go into the slides. That's okay.
Yeah. Perfect.
All right. So just to give you a sense of where we were before the onset or the official launch of T2 in June of 2020, in May of 2020, the Office of Housing Recovery Operations and the New York City Mayor's Office was directed by the city to conduct emergency procurement to identify vendors that could support the test and trace core through our resource navigation and aftercare navigation program to be able to meet the needs of New Yorkers who are isolating or quarantining at home. This fell to HRO for a couple of reasons. This includes their extensive experience with disaster mitigation, as evidenced by their initial role leading the recovery efforts around Hurricane Sandy. Through that work, the extensive community-based organization relationships that they had developed, and the additional expertise to provide to the T2 system in the realm of resource navigation. At the time, I think it's also important to bear in mind that the city's focus needed to be directed in different areas based on the expertise of certain organizations. And so at the time, H&H really was fully consumed with providing the medical response needed to see the city through its first surge of COVID-19. As a result of that request, HRO solicited 11 vendors to provide the following scope of services: hiring, managing, and coordinating resource navigators across the city, and then other duties related to administering the program effectively, including training, feedback and performance improvement, staffing plans, and then payment operation responsibilities. We can go to the next slide. So the evaluation staff reviewed the 11 proposals that were submitted using the following selection criteria. This included the degree of their longstanding community relationship, the availability of resources and the timetable in which they'd be available, cost, and then coverage across various zip codes so that we'd be able to provide deep connections across all 5 boroughs. After that evaluation, there were agreements issued with 5 CBOs and 1 agency, and those agreements were to expire on December 31st of 2020. These include BronxWorks, the Chinese American Planning Council, Consortium for Worker Education, Riseboro, Jewish Community Center of Staten Island, and CUNY. In July of 2021, 5 of those 6 agreements were then extended retroactively to cover the January to June 2021 period. And going forward, it was elected that JCC would only be retained through December 31st of 2021, and the remainder through the end of 2022. In the interim, we experienced another climate-related disaster in the city in the form of Hurricane Ida. And so with the need to close up work related to build it back in Hurricane Sandy and this new responsibility to tend to the consequences of Hurricane Ida, HRO no longer was able to properly attend to and support the Resource Navigator program despite its reduced scope. Because being able to provide contacts in cases with isolation and quarantine resources remains vital to containing the spread of COVID-19 in New York City, there is a need to reassign those 3 contracts for the remainder of fiscal year 2022 with an agency that is appropriate for managing this portfolio of work. Now, just to clarify and to make sure that we're on the same page about which contracts are actually in scope, JCC's contract, as you mentioned, ends on December 31st of 2021. Due to the reduced need, Riseboro will be ending their participation in the Navigator program on December 31st of 2021 as well, because we feel that with the 3 larger CBOs that we have available, we're able to adequately meet the needs of New Yorkers across all 5 boroughs, staff up effectively, and really efficiently administer the program with minimal overhead. So I've affirmed that there is an ongoing need to provide these resources to contain the spread of COVID-19 in the city, and this need will persist past December 31st of 2021. This is a service that fits very nicely within the existing portfolio of the Test and Trace Corps given its mission. There's no other city agency that is more appropriate for serving this need. And within the Take Care pillar specifically, it is a very appropriate complement to the other services we provide to help people isolate and quarantine. And those would include the actual delivery and operational components of Get Food, our hotel isolation program, and then mailing our Take Care packages, which contain PPE and various materials for people to isolate or quarantine at home if that is what they choose to do. And there's no duplication of services across these contracts. So to be able to continue this program, NYCH&H would assume these 3 agreements for the Chinese American Planning Council, BronxWorks, and CUNY to be able to conduct this program through the end of the fiscal year. I have the amounts, the contract terms and value of these agreements to be assumed by H&H To get them into the record for Bronx Works for the end of fiscal year 2022, that's January through June, would be $1,226,273. For CUNY over the same time period, $11,433,682. For the Chinese American Planning Council, $4,613,861 over the same term. And so in summary, we are seeking Finance Committee approval to accept this assignment of Resource Navigator contract for not.
Hello? Hello?
One
Hello?
second, Amanda.
Hi, is that Barbara?
Okay.
Yeah,
Yes,
Barbara
it's
Lowe.
Barbara. I've been on this line on 2 different phones for quite some time, so thank you.
Okay, great. We're just going through the first resolution now. Dr. Johnson, please go ahead.
So seeking Finance Committee approval to assume responsibility for these 3 contracts for not to exceed amount of $17,273,816. The term of the agreements would be January 1st, 2022 through June 30th, 2022. They're all with not-for-profit agencies that self-perform all obligations, and therefore they were not subject to MWBE requirements. The expenses would be covered by the T2 MOU between the Office of Management and Budget and H&H. With that, I will pause for any questions, clarifications, or other direction from the committee.
Thank you. Why don't I go through committee members to see if they have any questions? I'll start with Jose.
I have no questions. Thank you, Amanda.
Great. Dr. Katz,
No questions. Thank you, Dr. Johnson, for a good presentation.
Allie?
I'm sorry.
Oh, do you have any questions, Sally?
Oh, no, I have no
Amanda.
questions. Thank you.
Okay, thanks. Fenioski.
Thank you, Frida. Nice meeting you, Dr. Johnson. Really thank you for the presentation. Very comprehensive, very well articulated, and I just feel so confident of being, New Yorkers are in your hands. And I would like also to thank Ted for the incredible leaders that he brings through the T2 program and bring it to the board to speak to us so that we know all the individuals, all the faces that are making it happen. So thank you, Ted, and thank you, Dr. Johnson. I have a couple of questions. One is, I don't know if it is possible to share a little bit more of why some contracts are being concluded. It's like, for example, in Staten Island, there is no cases that we need to support. So I'm understanding that maybe the demand is coming down, but Omicron maybe is going to increase that demand. Is there something that could be shared in terms of the situation with those contracts?
Sure. And so, we, with the 3 resource navigation contracts that we have to date, we still are able to provide coverage across all 5 zip codes. I think all 5 boroughs, all zip codes. And it truly is the assignment of responsibility goes by zip code first because we want to leverage those local resources. I think having gone from a larger program when volume was higher and the needs were more acute to the program that we have now, which is pretty lean and efficient, we've absorbed some of that local resource knowledge that we gained from having a broader scope of community-based organizations in the beginning. The vast majority of our work with resource navigators is phone-based. And so physically being in the same borough is not essential for delivery of the resource navigation services. That being said, we also have resource navigators who do work in the field, primarily at our testing sites where there's rapid testing, so there can be immediate linkage to resources. And our staff are able to cover all 5 boroughs. So when we were at the ferry terminal, we had staff who weren't always JCC staff, for example, who were able to float down there and build relationships with community members and get out essential public health information. And so we feel confident that we'll continue to be able to serve all 5 boroughs to the same caliber of service with the 3 organizations that we've identified above.
Thank you. I think this is very helpful, and I don't know if it would be okay, Frida, to request that it's a little bit explained, either in a slide or something, that even with this reduction, because in the beginning slide you actually list kind of per borough somehow, and we don't want to give the impression that any borough will be without service. So if you can, and also to clarify, if there is any overlap between services in a zip code. So maybe there is a map that shows like which one of this organization will cover which part of the border, so that everybody's clear, everybody's covered, everybody will be supported, and we are there for them. So if it is okay, that will be something for the
Board
board, for the board meeting. Something that I did not hear in this report is that anything about performance. Is there any information that could be shared on how these different groups have performed? I don't know if we are measuring any complaints from some of the people that we serve, missed appointment, missed follow-up. I don't know what metrics may be using, but I think it is important for us to start to look at how the services are being delivered to New Yorkers and how our kind of support system is performing. Do we have any information about that?
So the ways in which we deliver feedback and assess performance of the CBOs includes qualitative and quantitative components. So on a weekly or biweekly basis, the Take Care and formerly Take Care and HRO leadership team would meet with each program director and relevant resource navigation leadership to talk about how things are going, what can be improved, what's a challenge, what might they want to share in terms of best practice with the other community-based organizations. But we also, since we're on the same Salesforce platform that drives the rest of the T2 operation, have the ability to provide quantitative feedback as well. Some of the things that we pay particular attention to are the percentage of research referrals that are reached within 24 hours. We aim to ensure that 90 to 95% of people who reach out to us do get the timely contact that they need. So that's one piece of aggregate feedback that we're able to provide. And then we're able also to track down to the level of the individual resource navigators so that they can provide coaching, training, and feedback to their staff. And some of the program integrity tactics that we use are for each referral, making sure that we've enumerated the services that they were linking people to, not just marking that it was completed, but what did we actually do. And so now you have this information, and I will coordinate with the board to see if there's any other data regarding actual performance of those CBOs that would be helpful for you all.
Again, if it is possible, again, I will defer to Frida and the team. If it can be presented, at least the 3 ones that are going to be continued, kind of some performance indicator. Not necessarily the ones that are not going to continue. I don't think we need to go there. At least that's what I'm thinking right now. But at least the ones so that people have confidence that the groups that are continuing first, they are going to have coverage of the 5 boroughs, but also the performance in terms of response time, whatever metrics you think is relevant, both qualitative and quantitative, may be helpful to ensure that everything is covered. And I know that I'm pushing my luck here, but I do have a third and last one. I can have more, but I will stop at 3. This bullet that you have here, you may not have been aware, but one of the discussions that we have been having on the board and with some of the other units is that it is accurate that the non-for-profit does not have to meet the MWB requirements, but we have been trying to ascertain kind of the representation and diversity of the non-for-profit, and even though you have a statement here, maybe because of my background, I like to see the data and not just the summarizing statement. If it is possible to show some of the demographics, at least again for the 3 that we are continuing in terms of the demographics of the management, both in the gender as well as racial ethnic distribution, the staff, and also their board. How are they? And that's the type of data that we are seeing now being presented for CBOs and non-for-profit in lieu of MWBE. So we understand more the composition of the group. I don't have any doubt that they do represent the communities, but I would like to see the demographic data. Again, I will defer to Frida and the team, but that will be my 3 requests.
And that also gives us an opportunity to comment on language concordance or language capabilities as well.
Yeah.
So very great point.
That's very good. I like that. I think very good. And if there is anything about disability that can be also documented, I think that would be good. That would be really appreciated. Thank you, Frida, for giving me the time.
Oh,
Appreciate
thank
it.
you, Phineas. All good points, and I am in agreement, Amanda. If you can provide some of that additional detail, I heard sort of 3 areas in terms of the diversity of the agencies, as well as the performance of the 3 vendors continuing, and sort of our coverage of and how we're providing the service and ensuring that everyone is covered. If Phineas, sees that summarize what.
You are excellent. Definitely. You
Okay.
said better than I did. Thank you.
So if that's okay, I think that would be helpful for the board, but you provided really good answers to that, and just having a summary of it in the final presentation. Thank you. Sally, I'll move on to Sally. Do you have any questions?
No, thank you.
And Barbara. Barbara Lowe, are you?
I'm here, yes. I have no questions at this time. Thank you so much.
Terrific. So we'll go ahead and take a vote. And first, Jose Pagan,
Yes.
Dr. Katz,
Yes.
Anioski,
Yes.
Sally,
Yes.
and Barbara.
Yes.
Great, and I vote yes, so the resolution is approved. Thank you very much, Amanda, for your presentation. Next, we're going to move on to Dr. Long, who is going to present the next resolution on a request to increase the not to exceed for the DOE and mobile testing units that we discussed several months ago. Dr. Long?
Yes, thank you, Frida. So I'll start by reading the resolution, then I'll dive into the slides. So authorizing the New York City Health and Hospitals Corporation, the system, to increase the funding for the 12 vendors listed in Annex A attached to this resolution, each vendor and together the vendors, from the $250,480,410 set in July 2021, when the Board of Directors authorized contracts for the vendors to perform COVID testing both in schools and in the community on an as-needed basis by $205 million to bring the total amount for all vendors to a new amount not to exceed $455,562,279. All right, just pulling up the slides here. So, okay. So by way of backdrop, as we go into the details here, and this, I shared the same thing with our capital meeting, but if you'll allow me, I'll just share a quick reason why this is so important to talk about today, is that we are seeing cases go up now, and we are seeing the new Omicron variant emerge in our city through community transmission. What's kept us safe throughout COVID, and what we need now more than ever, is to keep the line of sight that we have to know where cases are going up, where the variant is, and most importantly, what we can do to help people that are testing positive, and how we can help people that have been exposed to quarantine. All of that relies on our testing infrastructure, which I believe is the strongest in the entire country. What we bring back today are some of what we need to do in order to keep doing the level of testing that we're doing in New York City today, to keep that line of sight active and open, which enables us to do everything else we do for in the fight against COVID. So, in terms of backdrop to what we came to the board about previously, so to meet an expanding need of testing capacity, we conducted an RFP in June of 2021 to cover operations from August of 2021 to June of 2022 for COVID testing through 2 key modalities. The first, school testing. We offer testing, we do testing in all of New York City's public schools on a routine basis, and this testing is performed by bioreference labs, Fulgent Genetics, Somos Community Care, MedRight, and CIC Health. One other note about our school testing is we developed this surveillance program that is now the standard across the whole country and is a cornerstone of the CDC guidelines. When we studied our safety protocols in our schools, of which this again is the backbone, last year we actually found an interesting finding, which was that students and teachers in remote learning last year we're actually the same, if not more likely to get COVID than students and teachers in our schools in person. So the method of doing our surveillance testing here is a very important piece of our overall safety program for our schools that has kept our kids, our children and our teachers safe throughout. Community testing is the other pillar here. So we testing it with our mobile units and other types of at-home testing. Testing at home, saliva, employee mandate testing. And this is what we came to the board about back in June, July of this year. And these are things that we've continued to do throughout. It's currently executed by Rapid Reliable Testing, MedRite, Premier, and Mount Sinai. Since July of 2021, when the most recent not to exceed was approved, testing policies changed. This led to increased costs and a projected exhaustion of our NTE that we brought to you in July of 2021 that will be exhausted by the end of February of 2022, so a matter of months from now. Some of the key reasons about what changed between July when we last spoke and now, first is that the CDC guidance changed. The CDC guidance changed from monthly to weekly. And also there was a recent court decision that required the inclusion of non-public charter schools to be offered the same interventions or program, if you will, that we're offering to our public schools. And that includes our surveillance testing program. Another important change was the H&H's support of the New York City employee testing mandate, and also an uptick in community testing volume and deployment of our mobile testing to backfill decommissioned brick and mortar testing sites since July of 2021. As I shared with the board during our capital meeting, one of the things that we're very proud of is we've been able to double the size of our mobile testing fleet, but this is the cost associated with doubling the size of our fleet, again, giving us the ability to be driven by our communities to bring testing literally everywhere in New York City that our communities tell us we need to be, we are there. So all of that told with those changes, that is why we want to seek to increase our not to exceed from 250 million to 455,562,279 for testing from August of 2021 through June of 2022. This would be an increase of, again, 205 million. Vendor performance has been satisfactory to date across our vendors. So in terms of the programmatic changes, that's a high level, and I want to drill down into school testing and community testing a bit more to talk more about the impact of what we do. So school testing, the universe changed. It increased by 420,000 monthly. So to go into some detail here, the addition of non-public and charter schools added 120,000 students to the testing population. So those are new students we'd be testing. And also the increase of frequency from monthly to weekly made us do 4 times as many tests. So that brought us from 100,000, which is what we were planning before, to meet the 10% random sample, which is consistent with CDC guidelines of unvaccinated students, to now 400,000 tests per month. The average monthly spend was $30 million from August 2021 to June 2022 for a total of it would be $30 million for a total of 334 million over that period. On the mobile testing side, we added mobile testing capacity to bring the amount of tests we can do in a given month from 7,000 to 45,000 tests per month by December. We also added saliva testing, replacing our former microsite model. So you can go up to some of these sites where we do saliva testing, just go up, offer your sample of saliva, and that constitutes your test. We want to do 9,000 tests per month under that modality. And then with our brick and mortar sites, as we shared with the Capital Committee, we are continuing our current brick and mortar sites, but we also are building up our mobile capacity, as there have been some brick and mortar sites that we've needed to place mobile units at, so the communities always have the same level and opportunity for testing. If there were, for a variety of reasons, sites that need to be reclaimed by the landlord or building a school there or things like that. From our standpoint, our priority is to make sure that the communities always have the same level of testing. That's our commitment. So that also would ramp up to as many as 130,000 tests per month, or ramp down quickly as needs diminish. So our average monthly spend under this mobile testing would be of $11 million from August 2021 to June 2022, for a total of $122 million over that period. So these programmatic changes require an increase, adding those 2 final numbers up there, from the July 2021 not to exceed of 250 million to, again, 455,562,000 for testing to be completed through June of 2022. This is, again, an increase of $205 million. A couple of more notes on community impact. So I'm going to slide number 4 now. Thank you. So our school testing program, as I said on the 2 slides ago, has really been a cornerstone of our school safety program and has been what the CDC has since adopted as the gold standard guidance for the whole country. We've done nearly 2 million tests since October of 2020, just to give a sense of the magnitude of protection our surveillance program has offered. And our positivity rate has consistently been low, less than 1% in our schools throughout since October of 2020. We're the largest school district in the country. We're the first large school district in the country to open, and we've remained open, and testing is one of the key reasons why we've been able to assure the safety of our students and teachers. Mobile testing in terms of our community impact, the big picture here is that now that we've doubled the size of our mobile testing fleet, this is how we deliver to our communities our commitment to always bring testing where they believe it's needed the most. We have a very active and excellent T2 Community Advisory Board. I'll be meeting with them this evening. We have T2 community-based organizations that are our partners in this, and we don't make the decisions ourselves about where to bring testing. We ask our communities, and that's where we go. And I'm proud to say that, again, through doing this, we now have twice the opportunity to bring testing equitably across every community in New York City, guided by our communities. I'm proud we have the opportunity to do that. Okay, next slide, please. So I'm going to slide 5 here. So I'm going to go through some of the numbers here, and I'm happy to pause at any of these numbers too, because I know there's a lot of numbers on this slide, or happy to go back to it in the end, whatever the board prefers. So in July of 2021, again, we came to you for a not to exceed of $250 million over the 11-month period of August 2021 to June 2022. As of November 17th of this year, the actual spend to date, now I'm going to defer to my finance colleagues here about explaining some of the differences between the actual spend and the incurred costs. We've spent $14 million, but we've incurred costs closer to $75 million. With the trajectory that we're on now, we expect to have exhausted that not to exceed that we came to you about in July, again, by the end of February 2022. Which the reason we want to come back today is we want to continue doing our school surveillance testing. We want to continue to offer testing equitably to all the communities in New York City. In order to do that, we're going to be exceeding the $250 million not to exceed. So the final thing, I'll take a quick pause here in terms of the breakdown of the additional $205 million that we're coming to you about today. The balance of it actually goes to DOE testing, the school testing. So our DOE's testing is projected to increase by $183 million for a total of $334, whereas our mobile testing is projected to increase by $22 million, so less proportionally than our school testing change, for a total of $122 million over that same time period. So again, through June of 2022. And that's for a total of a little bit over $455 million. I'm going to take a quick pause here. I know these are a lot of numbers. So Frida, I just wanted to give the board a chance, if you or the board have questions about the numbers here, to go into more detail.
Why don't we, Ted, thank you for that, but maybe let's go through everything. We can have questions at the end. Does that work?
Perfect.
All right.
Sounds good.
Thank you.
Okay, next slide, please. All right. So slide 6. So this is our vendor performance to date. And this has a couple of numbers in addition to, I think, what the board's seen previously. So I think I'll draw your attention to the MWBE goal, which is the first column on the left after the names of the different vendors. The goal for, just to go through, Fulgent has been 30% in our utilization to date. It's 50%. Premier Assist 30% goal, 18% utilization to date. You see there that they've had a lower testing volume than some of the other vendors. MedRight goal being 30% with a utilization of 34% to date. Somos 85% goal, 85% to date. Rapid reliable testing 30% goal, 32% to date. BioReference 30% goal, 33% to date. And then some of the other ones we either haven't used or haven't completed enough billing for us to give an accurate sense of the percentage met to date. Other important things on this slide are the number of tests. So you can see the volume of tests by provider, and it ranges from on the Mount Sinai and CIC Health side, 3,000 to 4,000 when we drew this data, versus some of the larger vendors like BioReference, Rapid Reliable Testing, both doing over 100,000 tests. One thing that's finally important to note is the turnaround time column. It's obviously very important to me as the leader of Test and Trace is as a primary care doctor that wants to get my patients their answers fast. Our turnaround times many of them are above 99% of all tests conducted have a result returned within 24 hours. And that's true for Fulgent, that's true for Somos, true for Rapid Reliable, and you can see the other ones here as well. Okay, next slide, please. So this is our request to increase our not to exceed. School and community testing are critical components of our overall COVID-19 response and our ability to continue to give us the line of sight to keep our communities equitably safe. And I think we've done a very good job of this so far in New York City. This is our ability to keep doing that, keep holding the line, and keep letting our communities lead the effort with us. And also to keep our students and teachers safe in school while maintaining an in-person education, of which we're the first big city in the country to do. We have a lot to be proud of. We wrote the blueprint for this, the CDC has adopted. This is our ability to continue forward with the methodology that we developed that's been proven to keep our students and teachers safe. Existing approvals allow for a not to exceed of the $250 million that we came to the board about previously. We're going to be exceeding that around February 2022 due to the changes under CDC and the court decision that I referenced, and because cases are going up now. And we want to continue to maintain the same equitable community testing that we've had throughout. Therefore, to accommodate these changes, we are seeking to increase the not to exceed from $250 million to $455,562,279, allowing for $205 million in addition through FY22. This increase is covered by the T2 MOU between OMB and H&H, and I would love to answer any questions. Thank you.
Great. Thank you very much for the presentation, Ted, and for the great work. I'll go through and see if the members have questions, starting with Jose.
I have no questions. Just thank you for the great work, Ted, and the whole team.
Thanks,
Thank
Jose.
you. Dr. Cass?
No questions, thank you.
Thank you. Sally?
I was just thinking about the logistics for the Board of Education. You're going to go from testing students once a month to testing them every week. Is that what I read?
Yeah, pretty much. The one nuance is we take a random sample of unvaccinated students because those, of course, are the most likely to contract COVID and to potentially spread it compared to vaccinated students. This is consistent with CDC guidance. So the random sample, instead of drawing that once a month, we're drawing that once a week from every student.
And the random sample is like a percentage, or what do you base your random sample on?
10%.
10% of the unvaccinated student.
That we have consent for. That's right, and that's what CDC recommends.
Okay, thank you.
Thanks.
Thank you. Kenioski?
Thank you, Frida. Again, thank you, Ted. Incredible job, and you make it look so easy. How you are increasing fourfold. Let me tell you, some people will crumble to this, but you make it sound so. You did give a lot of confidence to everyone. I know that I have a lot of confidence that this will be match and exceed the expectations. I just have a couple of questions, if it is okay, Frida. If we go back to the performance table, please, if you don't mind.
Yes, that's slide 6. Yep.
There is a couple of things, and I know that you have mentioned in the past that all these firms are able to scale as needed, but I don't know if there is some sense of current capacity for each one of them to provide the service, and I will tell you why I'm asking. You know, you have two companies that are taking, well, one is definitely taking the bulk of this, so that kind of give me a little bit of a sense that we may be depending too much in one entity. However, they're performing, really doing well in all the metrics. So they may have a really good capacity. So it would be good to have a sense of that capacity. However, by your reference, again, we are picking here between small numbers, but it does make a difference. their performance in the 24 hours is in the 90%, but they are the second largest in terms of receiving. So I would like you to elaborate why is that, and that is. And then I see some others that are like really high performers, like Somos, that their volume is significantly lower. So if you can elaborate how these decisions are made and what are the quantitative measures that decide this allocation and this disproportion on the number of test allocation to conduct.
Yeah, it's a great question. It's if I had to use one word for it, I would use the word balance. You know, while each of these companies or each of these vendors individually has the ability to scale up or down, there are limits. One could not scale up infinitely, for example. So we put here some of the key data points for us, because, you know, if a vendor isn't able to get tests with their results back in 24 hours, I mean, that's obviously something that's very important for our fight against COVID, is timely being able to address cases and contacts. But, you know, other things that we take into account are what the vendor's internal capacity is. So some vendors on this list do have lower capacity than other ones. But as vendors get comfortable and as we work with them more, we tend to, if we have a good working relationship with them and they're hitting metrics like the MWBE utilization, like the number of tests we set out for them, like the turnaround time, and like being able to furnish the number of schools that are needed for our community or schools, then over time, if those things are going well, we do ramp up some. We may ramp down others based on their capacity and based on their performance in those metrics. So it is a little bit of a moving, in a good way. We look at these data points on a regular basis and make adjustments. It's if we share this with you, you know, in 2 months, it's going to look different than it does today based on how vendors have been performing.
I understand that, but let's give you an example. You know, look at Somos. He has more school units and half of the tests compared to bioreferences that have lower number of school units. The performance in the 24 hours 91%, but they have double the tests. How does that jive with what you just said?
Yeah. So so the turnaround time is one metric, but that is an important metric. So one of our vendors that performs well on that metric, like Somos, we would want to use more. Exactly.
Yeah, but you are not using it more. That's what I'm trying. That's my point. That's my point. Like, you are using bioreference twice the rate that you are using Somos, while Somos have like at least a quarter more school units. So and their performance is almost like perfect. So that is what I'm having difficulty understanding.
Yeah, well, if we share this again with you in a month, it's going to look different, and we want to use vendors. You're using the example of Somos, of course, but you know, other vendors have excellent performance too, like Rapid Reliable Testing. They have 99.8% return within 24 hours. So vendors like Somos or like Rapid Reliable, over time, we'd want to use more and more. And if vendors are having trouble, and I wouldn't say BioReference is having trouble though, but if they do have trouble, then we'd want to use them potentially less. So if we share this with you, you know, in a month or 2 months, we'd want to have the vendors that are performing better have more and more responsibility.
Okay, thank you. And maybe we can follow up on this, but one thing that I would like to, if it is okay with Frida, if we can put in this table something that shows a little bit about capacity, you know, what they demonstrate the capacity, not the potential to grow, but what do they have, so that we can see what excess capacity we're leaving in the table by this allocation, which to me, at least as the chart is presented, is very disproportional in some areas.
I think, Ted, is there a way to measure capacity? Is it by units?
Yeah, it's a good question. I'll have to think about that a little bit, because even with some of these vendors, actually, we're about to go into some other presentations today as well. They're drawn in different directions based on the policy directions that we go in as a city. So their capacity today is it may change tomorrow based on other policy decisions that have been made by the city. Well, I'd be happy to take it back, Fenny, and think about the best way to show capacity. I definitely get what you're saying there. In terms of being able to show, yeah.
Also, maybe, Fenny, that, you know, to me, I think of this as we're taking this in a snapshot in time. If we saw sort of a trajectory, you
Right.
might see, right, like we're seeing that Somos is performing very well, and they have capacity, and so we'll start to see that number increase. Like a snapshot doesn't tell us exactly what's happening because I don't know the time frame of these. Somebody might have, we started using them 2 months ago, and somebody else we just started a month ago, and so there's all of those kinds of factors in it. Because I know, for example, CIC Health
Exactly.
is pretty low on their turnaround time right now, but they've just started. There's a note that we saw that not doing well, and they've now improved that turnaround time, and it's in the 98% range. So the next time we see the snapshot, it might look very different. So I think, Ted, if you can give, because I do agree with Henioski, though, we want to make sure, like, we're, this snapshot tells kind of a story that is confusing. So if there's a way to try to demonstrate that trajectory, it might be helpful.
Yeah,
have a
that sounds good.
general related question, Ted. Where does Somos do their tests? And Somos is a great clinician provider, and they're providing vendors, but they don't themselves have a lab, correct?
No, which I'm gonna phone a friend here to see if we know what lab Somos uses.
I just say that as a way of saying that I think part of what's challenging is I'm not sure that in all cases you're comparing apples to apples. Because like BioReference is primarily a laboratory with some vendor capability of doing the swabs. I think Somos is entirely a swabbing operation. I don't know where they're sending the actual tests.
So actually, good point, Mitch. They sent the tests to the Pandemic Response Lab, which we're proud in New York City to have founded. It's a lab that runs our tests within our city control. So I think that's a big reason why they've had such an excellent turnaround. They're using the city lab.
So this great performance
Right.
is really H&H's great performance.
Well, the city's great performance.
But it's relevant, right? Because again, I assume that some of what BioReference tests are tests that they're being sent.
Hi,
Yeah.
Mitch and Ted, this is Kenra, and you're absolutely right. BioReference has quite a few swabbing teams, and they're going to send back to their own teams. Somos and your other vendors, Ted, are sending to Pearl, and you see the improved upon turnaround time for actual testing.
Got it.
Yeah.
Okay. I think these are very, very, very good points, and I just want to understand the allocation and the performance correlation, which I don't necessarily see it as clearly in some cases. So that's maybe you can think of. You have a great mind, put your great matter to work to come up with some ideas.
And Fanny, if I may, I agree with you. I think you have a point in time, as Frida said here. And one of the things we wanted to show in the point of time is just a snapshot of how people are doing today, how our vendors are doing today. But I'd love to think about a better way to show changes over time. That sounds good, and we'll bring that back.
Yeah, but this is cumulative. This is not just a snapshot. This is cumulative over time. I think what Frida referred is that their starting time, even though all the contracts were led at the same time, so they're supposed to have started, all the horses should have started running at the same time. It seems that some of them started not at the same time. So I understand that part, but here it's a cumulative, if I understand it. So it's not necessarily a snapshot. It's not like at this time during 1 month what you did. So I think you have to think a little bit more about this.
Yeah.
Okay.
That sounds good, Fanny.
And in order not to continue, because I'm hogging a lot of the time here, Primer Assist, I have seen this node of MWB certification like going on for several meetings. And from what I know of SBS, they are very quick in particularly cases that are already with a contract and of great need. So what is happening? Why they are still in this process? Because the SBS, they do turn around these certifications quite quickly.
Yeah, and you're the expert, Fanny. You know much more than I do about the process, of course. I believe it is still pending, but we will see what we can do. And as you can see here, as an example, the number of tests done by Premier is pretty different than the other vendors. Of course, many factors go in, as you pointed out yourself a couple of minutes ago. We look at multiple different metrics. But if there's more information that we can get about why it is still pending, happy to share that back. But I believe the current understanding, which is out of our control, that it is still pending.
I don't know, again, this will have to be done with legal and procurement, but I would say that a call to SBS will be very pertinent to find out what is happening, because my understanding, again, Jonelle Doris, who is the commissioner there and used to be the major MWB director, they turn around these certifications rather quickly. So I'm very surprised that it's taking so long.
Yes. Yes, we're happy to report back anything we hear, and the same goes if you want.
Okay, thank you. And again, sorry, Frida, for hogging so much time. Please go ahead. Thank you. I finished all my questions.
Okay,
Thanks,
not
Penny.
at all. Thank you. Good questions, Penny. Barbara, you have any
Yes, good
questions?
morning, everyone. This is wonderful. Thank you, Ted. I'm feeling that there's some hidden lines here in terms of the kind of reporting that we're doing. If I was to take strategic and maybe a couple other communities and overlay it with this data, we may actually come up with a phenomenal community impact statement for a community. I am so glad that the children and the schools are involved, but I think that we eventually, I think we will write that story based on our data and our involvement citywide. So I thank you. And with the collaboration, of course, with the city health department and Chiosky, I think we have a golden opportunity to have a wide lens and with specificity on how we've done and how the communities are faring. So thank you.
Yeah, and actually, Barbara, if I can just make a thank you for your comments. We actually have just published a peer review article looking at equity with testing. I'd be very happy to share it with the board. It came out for publication, I think, a week or two ago, so it's hot off the press. What you can remember when you're reading it, to your point, Barbara, is all of the way that we've been looking at equity and what we've achieved working with our communities. Think about doubling that with what we're doing here.
I would love to get a copy of that article. Thank you.
Clesia's on it. Yeah.
It should be. We should all get it and have a summation at the board, right?
Yeah.
Thank you.
Great. Sounds
Thank
good.
you, Barbara. Thank you. Great comments. Ted, I had just one quick question on, we're running out of time here, that you referenced some brick and mortar sites are being replaced with mobile. And I know we talked a little bit about this in capital committee, and there's very limited real estate costs in some of those sites, but is there any other offsetting savings that we might see as a result of that shifting? We're increasing this contract dramatically, but maybe there will be some reduction elsewhere. Is that?
It's a good question. Actually, I'll see if John or
yeah, I can answer this.
Please.
So looking at just like our average cost for our brick and mortar sites versus our mobile units, we will have, I think a pop-up tends to cost about 4 times as much as a single mobile unit. So there will be offsetting savings on the brick and mortar cost side.
Thank you.
Great. Terrific. Thank you. Okay, why don't I go ahead and call for a vote then? So let me go through the members. Jose?
Yes.
Mitch?
Yes.
Ali?
Yes.
Benioski?
Yes.
Barbara?
Yes.
And I vote yes. So the resolution is approved. And Ted, we are going back to you, I think, with the street health outreach and wellness application.
Great. Okay. Thank you. All right. So changing gears, the next resolution I want to read to you is for our street health outreach and wellness program. So authorizing the New York City Health and Hospitals Corporation, the system, to sign a 2-year contract with Rapid Reliable Testing New York, LLC, the vendor, to operate, maintain, and supply mobile healthcare units to provide primary care services to homeless individuals living on the street through its Street Health Outreach and Wellness SHOW program with 2 one-year options to renew that can be exercised only by the system at a cost not to exceed of $21,806,323 over the potential 4-year term. Okay, just gonna pull up my slides here. Okay. All right. So, by way of background for this. So when the vaccine first started to be available in New York City, I remember the time we were rushing to build our new sites to get the vaccine to our most vulnerable populations concurrent with doing that. And that's where I shared with the board at our capital meeting our strategy working with NYCHA developments, in which we've been at more than 60, bringing things like the vaccine literally, again, not just to your doorstep, but through your doorstep. And equity has been really the cornerstone, working with our Department of Health, the best in the country, all the way through. Now, one of the challenges that we encountered early on, that we knew we were going to encounter, is being able to bring the vaccine to people if we don't know where they are, especially homeless people that are living on the street. So we developed this model early on called Street Health Outreach and Wellness, where we came at it with the contention that maybe if we offer people that are homeless, living on the street, using drugs, other services that they might value, that might enable us to have that right conversation about getting tested or getting the COVID vaccine. And I remember early on, I went through a walkthrough with one of our teams. We went through, the first gentleman we went up to was somebody that was asleep under an overhang. And he did not want to talk about the vaccine until he talked about the wound on his leg and his wound care. So from the very beginning, actually, wound care, it's not an uncommon example, has been a cornerstone of this. Again, really trying to bring people the types of services that they would value. And we kept building upon that. And every time we hear about something else people would value ranging from, mental health to hypertension, we'd built that into the model. And then we'd use that as a foray into talking about getting tested and getting the vaccine. So what I'm bringing to you today is built on that backdrop of the really dramatic success we've had vaccinating people that are homeless living on the street in New York City, arguably some of the hardest to reach populations in New York City. And we've been able to be successful because we've met them where they are and given them what they prioritize as a way to talk about the vaccine. And now we've been able to open the door, and I'm going to tell you about what more we want to do in the future moving forward, built on the success we've had so far. So certainly this population of people that are homeless, living on the street, and using drugs, oftentimes in public settings, lack reliable access to healthcare, exacerbated negative health outcomes. We do have in our system today primary care safety net clinics, which are phenomenal clinics within the four walls of our hospitals. We have one at Bellevue, one at Woodhull. The one statistic I'll give you for them is that I'm proud to say in New York City Health and Hospitals, in our private primary care safety net clinics, we've achieved better diabetes control for our homeless diabetic patients than the rest of our diabetic patients across the whole system. So really, we have a model here that really works, but we want to make the right connection points between our vehicles, our units, our roving teams that are going out there in the street every day, and the models that we have within the four walls of our hospital. This proposal today will unite the two. On slide 2, I've talked about a lot of this. We provide basic clinical services, wound dressings, evaluations of symptoms, behavioral health supports, even snacks and hygiene products we can give to people. We currently have 6 units operating under emergency declaration signed by Dr. Katz on May 21st of 2021. Again, the emergency we were dealing with at the time was quite emergent, which was how do we vaccinate some of the most vulnerable New Yorkers who are living on the street and were homeless. The program to date has been fully vendor staffed and operated. The vehicles operate in neighborhoods with known high unsheltered homeless populations. We built partnerships with local community partners as well. That helps us to navigate where we're going to have the units and how we're going to engage the communities there. It's also done in close coordination with other city agencies and City Hall. A challenge to date, and so this is the last bullet on slide 2, is that because it's been a vendor-run model, we haven't been able to use our Epic EMR, which is one of the best ways to connect to our brick and mortar sites where we have our primary care safety net clinics, which are evidence-based, and we very much believe it. So I'm going to go to slide 3 now. So this contract would engage a vendor to provide the vehicles, to operate and maintain the vehicles, and to operate and maintain the supply and stock the vehicles, so that we at H&H can make a change. Instead of having the clinicians come from the vendor, have the clinicians and the teams come from us. In fact, what if we had the clinicians and teams coming from us be the same clinicians and teams that are in our primary care safety net clinics? So if I go to somebody in the Bronx and I see them and I have a conversation with them wherever they are, meeting them where they are, I can actually say, we've had a good conversation. We've talked about your mental health. We've talked about substance use. We've talked about hypertension. why don't you come tomorrow to open access, come whenever you want. And it will literally be me that you'll see at Lincoln Hospital, at Bellevue Hospital, to continue our conversation. I think that in primary care, that continuity is just the backbone of everything we do. So the staffing model itself, this would be, we'd staff clinic, we'd provide the teams and the clinical staff, of course, through H&H, and those would be provided through the primary care safety net clinics to forge that incredibly strong connection that we want. It would include doctors, PCAs, nurses, clerical staff. We're still working through the details of exactly what the team will look like, and this is something that we're going to be perfecting over the coming months. And also having a community health worker from our new public health core, which is separately funded by the public health core as part of each of these units as well. Of course, one thing I want to spend just a minute on here is that for this population, behavioral health is absolutely essential. And that we want to try to forge many connections with behavioral health, both in our hospitals, but also in the moment where we have somebody that we're talking to that's right there, maybe sleeping on a sidewalk or sleeping on the street. So we want to be able to have social workers there as part of the clinical teams that would actually be able to leave the units, go out with our roving teams, meet people wherever they are and see where they're at, what their priorities are, and figure out what we need to, or how we can talk about some of the important issues that are important to them and are important to our ability to help them. We want to have addiction counselors, peer counselors, and social workers to do this good work. We also want to bolster, we're going to have and want to bolster our primary care safety net clinics, which are in the four walls of our hospitals with dedicated psychiatrists. Our vehicles have the ability to use telehealth to tap into those psychiatrists to provide a higher level of behavioral health care. And whenever possible, we also want to redirect patients and reconnect them to other behavioral health services. If they had a good relationship, let's say at the VA, but for a variety of reasons it's fallen off over time, we want to make sure we can make those connections as well. I'm going to go to slide 4 here. So in terms of the procurement to date, on October 21st, we published an RFP in City Record. It was sent directly to 29 vendors. On the 28th, we had a pre-proposal conference that we held. 8 vendors attended. On November 8th, was the proposal deadline. We received 3 proposals. On November 17th, we answered clarifying questions, or the clarifying questions from the evaluation committee sent to the proposers. And on November 18th, the vendor responses to the questions were received. November 19th, the evaluation committee completed scoring, and Rapid Reliable Testing, LLC, was the highest rated proposal. Next slide, please, slide 5, thank you. So Rapid Reliable Testing was the highest scoring proposer. This is the vendor that currently operates the SHOW program, so they're a tried and true vendor. Their other relevant New York City experience includes our mobile testing units for T2 from December 1st of 2020 to present. They performed over 600,000 tests to date. And they also operate mobile vaccine units under the New York City Office of Emergency Management from, again, December 1st, 2020 to date. They perform more than 150,000 COVID-19 vaccinations to date. Next slide, please, slide 6. So these are our RFP criteria, and I'll talk quickly through this because I know we're a little bit short on time. Our minimum criteria was prior experience providing a client with at least 5 vehicles, prior experience in maintaining and operating at least 5 mobile medical clinics, MWBE utilization plan waiver or MWBE certification. Our substantive criteria were 30% cost, 30% relevant experience, 20% service standards, 10% ability to scale, and 10% MWBE. And our evaluation committee was comprised of our AmCare Deputy COO, our Director of Implementation in AmCare, Director of Clinical Models, Clinical Planning, Operations, and Care Models, Senior Financial Analyst, Budget and Finance, Senior Director of Behavioral Health, AVP Pharmacy, Director of our Primary Care Safety Net Clinic at Bellevue, Behavioral Health Physician at Lincoln, Community Health Worker Supervisor at Woodhull, and AVP of Christine's OFD. Next slide, please. So in terms of the summary, our applicable MWBE goal was 30%, and the awarded vendors MWBE goal was exactly that, 30%. The way that they would reach that 30%, we map out for you here under the utilization plan with 3 sub-vendors here with the total utilization plan goal of 30%. And of course, Rapid Reliable Testing has agreed to the 30% goal to be split between the 3 certified MWBEs, with individual subcontract amounts to be determined. Next slide, please. Okay, so we're on slide 8 here. So the request, the Office of Ambulatory Care and Population Health seeks Finance Committee approval to award a contract to Rapid Reliable Testing for providing the vehicles, operating and maintaining the vehicles, and supplying and stocking the vehicles for the Street Health Outreach and Wellness Program for $21,806,323 over 4 years. This is a 2-year contract with 2 one-year renewal options at the discretion of H&H, and additional funding from the city required to support H&H staffing goals, with the important point being here that this contract we're talking about, this resolution we're talking about today is for a contract, again, for the vehicles, supplies, and maintenance of the vehicles. We at H&H would draw from our evidence-based excellent primary care safety net clinics, which are very effective, and have those same staff be on the vehicles to provide the strongest possible connection for longitudinal primary care. For the total RFP expense, the total again is the $21,800,000, and we break it down here by fiscal year. Okay, that takes us through, and Frida, happy to answer any questions, and thank you again.
Great, thank you, Ted. Why don't we quickly run through questions, Jose?
I don't have any questions. Thank you.
Dr. Katz?
No questions, thank you.
Senioski?
Okay, thank you, Frida. Thank you, Ted. Today, the meeting is the TED show.
Sorry.
So, and since we are seeing all this together, so you can imagine that one looks at all these contracts kind of in connection. So here we have Rapid Reliable Testing. This is the same firm that is doing the bulk of the other testing with the 300 plus. They are doing okay. They are meeting their goals. You know, like 33, if I remember. So they are meeting. My question is, it looks that they have capacity, and they seems to be doing very well because we are going with them again. How are they in terms of undertaking this contract? Are the MWB that they listed here the same that are working in the other contract? How are those MWB in terms of capacity to undertake those 2 contracts? I don't remember seeing in the prior contract the list of the MWB for rapid reliable testing. So I don't know if they're the same, but if they're the same, what are the capacity and is there any concern?
Yeah, great question. So to take it through, so they are the same sub vendors. So they have a proven track record, and as we shared before, they've met and actually slightly exceeded the goal laid out for the other program. One thing to note here, Fenny, which is important, is as again, the rapid reliable testing in terms of the testing and vaccine world is providing all the clinical services and the vehicles. This is exclusively just for the vehicles, maintenance and supplies. We're going to be doing all of the clinical services ourselves, which is a pretty different model. And I say that only to make, because you bring up the good point about capacity. So we are the ones that are going to be providing the clinical teams and capacity as the cornerstone of this model.
Okay, but we evaluated their capacity for the vehicles component because they have the vehicles component in the other and they are and this one. So we look at that and there is no concern.
Correct.
My only recommendation is, you know, again, there are companies and we see a lot every day that have the ability to meet all their obligations, but sometimes some of them can can try to swallow more than they can chew. I don't know, I forgot what is the correct expression, but bite off more than they can chew. Okay, thank you, Ted. I will just recommend that maybe in the monthly or whatever timing you use to really look at the issue of capacity and ensure that they are not stretched too thin. These are sizable contracts. I really don't know. Do you know how long rapid reliable testing has been in a system? Because I noticed that a lot of these testing companies kind of sprung off with COVID. So is this one that has had a track record for so many years, or is one of the newcomers that have been doing very well?
Good question. Phone in a friend.
Hi there, this is Chris Keeley. Nice to speak
Hi,
with you again.
Chris. How are you?
Good. So some of their history, they have been operating as an ambulance company in over 30 states across the country for over 10 years, maybe even over 15 years. They also operate as an ambulance company internationally. They're also the ambulance provider, medical care provider for the New York Mets, the Brooklyn Nets, a number of other professional sports teams, I think the Rangers as well. And they operate on a range of outpatient support services, traveling home care services. They provide a range of services. So they have been a long-standing company that sort of stepped into the COVID space when this time came, but they have been a long-standing company.
This is a very good information and give me a lot more. It kind of helped me calm down a little bit. So again, if Frida is okay, maybe elaborate a little bit about that, their history, where they come from, their reliability, and maybe their volume of work, you know, like last year pre-COVID, how much money they were doing, so that you understand that this is not something that's spun off overnight, but it has a very long track record and they can handle it. I think that, at least for me, what you just say make me feel a lot more comfortable. Thank you.
Yeah, also,
Yeah, we'll do that.
Penny, just on that point, it's they started as I thought of them more as a testing company, right? Really, they are more of a vehicle company. So this shift actually makes a lot of sense for us in terms of what we're looking for and what we need. So I do agree with you, Penny, just providing some of that context, especially their name is Rapid Reliable Testing, it's
Yeah.
it's
Touche.
Reliable driver.
yeah. So, okay, anyway, I don't want to belabor. Penny-Oski, did you have any other questions?
I think I have taken a lot of the time of the meeting. Thank you.
Thank you, Penny.
Sally, I skipped you.
Yeah, I'm trying to wrap my arms around, because they're two separate pieces. They're the vehicles and then there's the staffing. You've two lines. One, you've done this for about 6 months now. So I was interested in about how many folks you helped and what was the staffing model you used in that period. Two,
Yeah.
I'm a little concerned about taking funding from the the primary care safety net clinics. Do you see at some point requesting additional funding to get more dedicated staff or some of the staff members? The issue of staffing is one that I'm struggling with a bit.
Yeah, totally. So two good questions there. One, what's the staffing that we've used to date and how does that relate to the staffing here? So to date, the staffing model has been similar. It's broken up into a roving team, so a team that actually goes out and finds people that were advised about by the department, by DHS, or even by other community entities. And then we go to them and see how we can help them. And then we also have the teams that stay on the actual next to the units themselves. We're basing what we included here off of what we've seen successful in our last 6 months, but we're going to keep thinking about it and give it an H&H flavor, make sure it makes sense. So this is the staffing here is not absolutely set in stone. We want to think it through more. And then moving forward in terms of the time of the teams when they're not in the primary care safety net clinics and they're part of the SHOW program, we are working with the city to fund all the aspects of SHOW. And we've gotten a written commitment from them to fund SHOW, which includes the vehicle portion, but then there's the clinical portion too. And when we spend a little more time making sure that we've perfected and refined the model with everything, to your point, that we've learned over the last 6 months, we'd be going to the city for that funding as well.
And about how many folks have we helped over the last 6 months?
So we've helped over 70,000 people over the last 6 months.
You've actually gone out and met with
more than 70,000 people.
That's amazing.
Yeah, it's been people in New York City, as I like to say, Sally, you know better than I do, but they vote with their feet. They're not going to spend time with us unless they see value. So it's encouraging.
Yeah, it certainly is. Thank you.
Great. I agree.
I'm sorry, do you give them vaccines? Do you provide vaccines? You do?
Yes,
Okay.
definitely. I've been with the teams where we've We actually delivered a vaccine to an individual who was laying down. He didn't want to sit up for it, but that's okay. We'll meet everybody where they are, and he was safely vaccinated today.
Great, thank you. Sorry, Frida.
No,
Thanks,
that's
Ellie.
great. Let me move to Barbara quickly.
No comments, thank you.
Okay, terrific. And I'm not going to make any additional comments because it's really terrific. I think the one thing I would like to ask is if we can, is there a way that you'll be able to kind of track the effectiveness of shifting this, you know, so that we can, in getting patients into care at H&H from the, I know there was only a few months of experience with the program prior to this, but
Yes.
Yeah.
And two of the metrics we're going to be looking at, we put a lot of thought in this. We're very excited about all this. One is, which we've seen at the sites where we've been at the longest, is the over time how patients come back to us for more care. So
Right.
one of the sites in Harlem where we've been at the longest, now on a given day, a quarter or a third of the patients we see there, we've already seen before, and they trust us enough and value what we're offering enough that they want to come back and re-engage in care with us. So we're going to be looking to build those relationships over time about people coming back to us. Now we're going to be looking also at the number of people that we're able to bridge from the actual units themselves into the four walls of our primary care safety net clinics, where we know we can provide such high quality care that those patients have better diabetes control than the rest of our population.
right, it would be terrific to get update on this, you know, at an appropriate time.
We'd love to.
Great, thank you. Let me go to a vote. So Jose?
Yes.
Mitch?
Yep.
Sally?
I'm excited about all of the Ted Long resolutions, but I'm particularly excited about this one, yes.
Thank you so much.
Great. Benioski?
Yes.
Great. And Barbara?
Yes.
And I vote yes also, so the resolution is approved. We have a financial update, which is a terrific update, and I very much want to go through. But John, Lisa, you let me know. Do we have any time to?
If we can do just one or two highlights in 10 minutes, and we can start the audit in 10 minutes. And we do have an audit committee meeting in January that we can do a full, complete financial update.
A finance committee meeting, you mean, in January?
Yes.
Right? Yes. So, John, I know the team has prepared a great amount of good information that I really do want to go through in January, but unfortunately, I am a bad keeper of time, so I may be out of time again. So, is it possible to hit some highlights that you think are important for the committee to hear about right now, and we will do a home meeting in January?
Sure, well, that sounds good. It would go faster if we had Ted do it, but I'll do my best. Yeah, I think, you know, thank you for your time, and I'll go quickly through this. You know, I'm pleased to report, you know, I think the system is stable, right, throughout COVID. You know, we've done a lot of, you know, good hard work. We stayed, you know, with our game plan, and we're going to close in October. We closed in October with $350 million in the bank, about 16 days. What's somewhat unfortunate is that we missed our budget target by $152 million, which we've not missed our target, certainly by much. But it's all attributed to the fact that we've not yet received the FEMA funds that we are counting on. And I want to just, you know, say that we're very grateful, right, for the advocacy from the delegation, Senator Schumer's office, and Congressmember Torres, and we have their full attention, and we have the full attention of FEMA as well. And we want to continue to be, you know, good partners with them. But obviously, at this point, this juncture, you know, we're putting up the red flag, and we've been told that we have the full attention of the central office and FEMA at this point, and hope to make progress with them over, you know, the next month into January. So I think we'll be okay there. The fundamentals, right, continue to improve. Direct patient care receipts is up almost $118 million over the same period last year. But what I think is most remarkable is that's on top of last year's performance of $468 million. So the trend line keeps, you know, going in our direction. Patient care volume is coming back. We're still a little bit lower than pre-COVID, but 4% below on discharges and 6% below on outpatient. But I know today that the inpatient beds are very full, and we're planning accordingly. So the volume is definitely back. As I've mentioned, our financial initiatives, despite COVID, still making our targets, spending a lot of time focusing on that with Matt and Chris Roker and the whole team. And we've generated over $160 million in the first quarter. We have a line of sight of 606 for the year. That will fluctuate right during the course of the year. It always does. But again, those metrics all moving in a good positive direction. And then we kind of highlight, down below, those areas where we're seeing remarkable performance. I can quickly just go through a couple more slides, Frida, if you'd like. Yep, I can go to the next one. I think there's some good information there. So our cash projections, October at 350. We expect to close with 400 in the bank. And as I had mentioned, the FEMA was generating the shortfall. We're going to close that shortfall in December and January with the performance in the other two items there, the UPL conversion, which you've heard me talk about, and VBP QIP. Those dollars are now flowing into us. So that will be the bridge, right? That'll be the bridge. It'll buy us some time. We're grateful, right, to the health department and the health plans that have partnered with us on these transactions. We're still working through a couple more, but overall, our experience with them has been very, very appreciative. And we owe some money, back to the city as part of our, financial, movement of dollars, between years. So, but we're good with all of that, and the city, OMB, obviously been a great partner with us throughout all of this. So from a cash perspective, I think we're fine. We're going to do, some work with you, Frida, just kind of laying out some more of the details of the cash plan. Watch it very closely.
Right. Great.
James does. Yeah. Yeah. So yeah, I think anything there, James, you'd like to add to the cash stuff? Yeah. I can go through just a couple more here, and then I think on the risk, is there a risk slide? The next is there a risk slide? Yeah. COVID. Yeah, I think we can skip over that. So we keep watching the risk. I think this we pretty much have covered. You've seen these slides before. We did apply for phase 4 PRF funds. We've not heard back. And hopefully we'll soon. But we did fill out all the required paperwork there. It's managing the external risk, right? Those are the things outside of our control that we pay particular attention to. The list was longer last year. We took some off. In terms of the state and Medicaid initiatives that I mentioned, UPL conversion is coming in. The state city budget risk, right? We watched that. The state has announced last month in their mid-year update that they're exceeding their revenue target by $4 billion, and that I think they're fiscally sound through 2025, and even had enough money to put some in reserve. So that's all good. We think the city's budget is fine as well. So again, we're checking that risk off. FEMA, I had mentioned. Vaccine mandate, right? We're still looking at all the costs related to the vaccine mandate. We'll have a report when, the next time we meet. But we're sorting through that. We feel pretty good, better about it than we did before. The enhanced nurse OT program has been a great success for us, where we're actually paying our nurses double overtime, and we had a remarkable take-up rate in interest. And we plan on relying that on through January, maybe using that as a substitute for contract nurses. So more to come there, but we definitely appreciate the effort from our nurses in helping us out when our beds are full. So we will continue to utilize that. I don't know anything else that we should.
I think that is a great overview. I want to just make sure if there's any burning questions from the committee members that we can get to them. Some of this other information, which is on the strategic initiatives and revenue cycle, I want to have some more time to discuss. So, and the budget. So perhaps we push that to January. Does that work?
Certainly.
Okay. Then apologies for that again, but let me just make sure we don't have any questions. Jose?
Thank you so much.
Great. Dr. Cass?
Oh, and we don't have full time, but I have been working with John, and I'm confident of the work that finance has done. I think we're in a very good position.
Great. That balancing a lot, you underscored you underplayed the risk, John. There are a lot of them. So thank you and the team. Sally.
Just a quick question. We have remaining liabilities to the city, and I know we work with them. About how much are they, and are they included in the figures now, or we just have them to the side for now?
We owe them about $600 million in total, and it's part of our overall financial plan to pay it this year. We don't have a specific time to pay. We pay it as the cash is appropriate.
Okay, thank you.
But it's all in our plan to be accommodated.
Yes.
It's not like we're saying we can't pay them. It's just a matter of when.
Exactly. Okay.
It's more the cash flow
Yes.
bridge, right?
Question, right.
I'll just say also that, this is how it normally is. This is how it was in Los Angeles. This is how it was in San Francisco, right? It wasn't, nobody was concerned as long as the money was booked from a secure source like FEMA. It's natural that the city is going to be the backstop because the city obviously has a much greater ability to garner resources than health and hospitals alone, and that most organizations are completely on an accrual basis, and an accrual basis would show us to be in great shape and not short any money because we have expected dollars for the services we've provided. So to me, the money owed to the city is just the way life works. I think once in Los Angeles, I was up to owing a $1.5 billion to LA County because of the delays in payments. It's just common that this is how it works.
Is that before you came here, Mitch?
Yeah. But I was in positive budget. It's just the difference, as John is explaining, between when you have the expense and when you get paid, right? It wasn't actually a problem, and I think at that time the state of California had owed the county of Los Angeles like $3 billion, right? So all of it is just a question of who's paying when.
Right.
Okay.
And thank you.
Yep. And our financial statements show that, Rich. You're exactly right on budget. So let's see, Sally Fenios. Who's Fenny?
He dropped off.
Oh, he did. Okay. How about Barbara? Barbara's still on.
Yes, I'm still here. Yes, I am. John, if our interim governor was sitting with us today, what big question would she have of you?
What would she have of me, or I would have of her? How
about that?
Yeah, both. Yeah, I think so. And I think a lot of people are starting to prepare for the budget. And tomorrow we are actually going to Albany and meet with some Ways and Means and members of the Assembly. But I think when I referenced the $4 billion as a net positive, right, to the state, we're not anticipating any cuts, and it gives us the opportunity to make wise investments, particularly for safety net hospitals. And there's just been an accumulated, impact of cuts over the years that are going to have to be reversed. So we see some opportunity in this year's budget. There's a coalition of safety net hospitals. We want to be part of that coalition. We want to make some investments in areas that we think will help us out. So I would just say that we look forward to being a good partner with the state as they put together their budget.
Wonderful. Thank you.
Great. Thank you, Barbara. Thank you, John, and the entire team. And we will definitely carve out time next month. So is there any old business? Any new business? So there being no further discussion, the meeting is adjourned. Thank you, everyone.
Thank you.
Have a good
Thank
day.
you.
Bye-bye.
Thank you.